Hello, this is Dr. Schminke, and in this lecture we're going to be talking about menstruation and the menstrual cycle. The video links that are in this PowerPoint are there to help you if you need more clarification. We will first start out talking about normal and what is going on with the hormones of menstruation and things like that. And then we're going to talk briefly about dysmenorrhea, about premenstrual mood disorders, and about endometriosis. Let's get started. The learning objectives for this PowerPoint are much as I just described on the previous slide, and they're all written here. Before we get too far into this lecture, I want you to become familiar with some terms related to the menstrual cycle. We talk about menarche, which is the time of the first menses that occurs, the onset of menses for young women. Usually that's at about 12 and a half years of age. There are stages of the menstrual cycle that we talk about throughout the lifespan. There's the reproductive stage, and you move out of that during the perimenopause and then into menopause and the postmenopausal phase that we will talk about in great detail in future lectures. The menopause, I do want to note, is a retrospective diagnosis. You have to have missed 12 consecutive cycles of menstruation before we can say you are at menopause or postmenopausal. I just said that menarche usually occurs around the age of 12 and a half years. There's been a lot of press in the sort of, not in the research press, but in the general media, the suggestion that girls are going through puberty earlier. And so we need to ask ourselves if that's really the truth or not. And I have to say that there's a lot of methodological issues with the studies that have looked at this, and I'm not sure that we can say that. There are many experts in this field who are not certain that we can make this claim that puberty is happening earlier. There is such a thing as premature puberty, and the definition is that it's puberty that occurs before 8 years of age. There are two aspects of this for you to be familiar with. Premature adrenarche, and that's where you suddenly have the adrenal glands producing DHEA, and the end system effects of the DHEA coursing through the person's body in larger amounts than it used to is the development of pubic hair, body odor, acne, oily hair, that sort of thing. And another thing that you might witness would be premature thelarche, which is premature development of the breast. Now, this is something that you need to distinguish between, is it thelarche or is it lipomastia? Lipomastia is what happens, well, it turns out that it's really difficult to distinguish adipose tissue from breast tissue if you just look at somebody's breast. But to evaluate the difference, you actually need to palpate for breast bud under the nipple. And of course, that's not something that researchers do a lot, and even primary care and pediatrician primary care folks are not always doing. And so we get these labels of puberty attached to people who actually are just, because they are overweight, they have a lot of fat around their breast, enough that it looks like they're developing breasts, and that's called lipomastia. So if they don't have a palpable bud, it's lipomastia. It's not breast development. It's not thelarche. The big question when you have a 7-year-old in your office and you're trying to figure out if these symptoms are, is this premature puberty or not, And if it is, you need to ask yourself, is it benign or pathologic? And the best way to figure that out is to follow patients see them every 4 to 6 months and watch their growth charts, because they do need to be referred to a pediatric endocrinologist if they have both progressive breast development and they're actually crossing the linear growth percentile channel, like their growth is coming up out of one part of the curve, one of the lines on the curve into another channel on the growth chart, because those people at less than 8 years of age need to be evaluated. One of the reasons to figure out if somebody is experiencing precocious puberty, central precocious puberty at age less than 8, is that we do have treatments available. GnRH analogs can be used to preserve height potential, because untreated precocious puberty, kids that are going through that may experience early completion of their growth, and they end up being quite short. This is especially true in kids whose height is below the 50th percentile to begin with. It's almost never the case if their height is at the 90th percentile or above on growth charts. The bottom line for all of this is that I want you to watch carefully. I'm not expecting you to memorize any deep details of issues around menarche and pathology, but I want you to know that you shouldn't just reassure parents that, oh, puberty happens early now, and ignore it. It does deserve careful watching on our part. Okay, I've said that. Now let's go talk about the menstrual cycle. What do we mean when we talk about normal menstrual bleeding? Well, we've established that it's going to happen after the age of 8 years old. And for most women, when we talk about ovulatory menstrual cycles, they're going to last between they're going to occur between every 24 and 38 days. And for most people, it's going to last approximately 5 days, although the majority of the blood loss is going to occur in the first 3 days. Anything less than 8 days of bleeding is considered normal. The average volume of blood loss is 30 to 40 milliliters per menstrual cycle per period, but normal is really anything from 5 to 80 milliliters. Normally, menstrual cycles are predictable in most women, but there can be some variation of a couple days per month. So you might have a cycle that's 28 days, and then one that's 30, and then one that's 28, and then one that's 29, and then maybe one that's 27. And that is not an irregular menstrual cycle. That's actually very, very regular. And as people are going through puberty and starting to menstruate at menarche, and again during the perimenopausal transition, you tend to get a lot more unpredictability to when people are going to bleed, how regular they're going to be. In fact, it's very normal for a young teenager to have very irregular menstrual cycles, and it's also very normal for a woman at the other end of the reproductive span to have very unpredictable menstrual cycles and to skip months. Now, when we talk about menstrual cycles, we usually measure the frequency by talking about when their last menstrual period was, their LMP. And when we do that, we chart the first day of bleeding as their last menstrual period. That's the first day of their last menstrual period. That's the date you should record in the chart as their LMP, not the day they stopped bleeding or some day smack in the middle. You are going to need to see a patient if they are bleeding more frequently than every 21 days, if bleeding lasts longer than 10 days, or if bleeding is heavy enough to soak a maxi pad in 1 hour or less for several hours in a row. And that's counseling that you should be giving to your patients, and make sure your front office staff or whoever schedules appointments is aware that these are things that need to be evaluated.
So, the menstrual cycle, I have these two terrific videos that I'd love for you to watch. The first one is a great introduction. The second one is hopefully a review for you to really solidify your understanding of what goes on in the female reproductive cycle. But basically, we have two phases of the menstrual cycle, the follicular phase and the luteal phase. Some people will break out the follicular phase and talk about the menstrual phase, which is when you're bleeding, and then the proliferative phase of the follicular phase of the cycle, when what's going on is that the egg is growing to maturation to prepare for ovulation. So the follicular phase comes first, and you have this feedback loop between, as your estrogen levels are dropping, the hypothalamus is stimulated to release gonadotropic releasing hormone, which in turn stimulates the anterior pituitary to release follicle stimulating hormone, or FSH, and luteinizing hormone, LH. When LH spikes, you get ovulation. FSH is working on the follicles in the ovary, which are its job. The FSH is actually changing the hormonal environment of those follicles from an androgen dominant environment to an estrogen dominant environment. And this is a cycle that feeds back then again to the hypothalamus. Now on day 14, you get the release of the egg with ovulation, leading to what remains in the ovary is the corpus luteum, which is going to be producing progesterone and a little bit of estrogen, and it is going to be the main producer of hormones if you actually were to get pregnant. If that egg were to be fertilized, until the placenta is up and running, the corpus luteum is going to be doing all the work of keeping you pregnant by making hormones that are going to keep you from having a period. And so the progesterone, of course, your conception won't happen probably until at least day 16. In a normal 28-day cycle, and the progesterone is going to be preparing that endometrium, the lining of the uterus, to receive a fertilized egg by the time it travels through the fallopian tube and then can find its spot to rest in the uterus. If there's no implantation, then the arteries of the endometrium are going to spasm, which will block the blood supply, and then the lining will slough off, which is what your menstrual period is. It's the sloughing of that endometrium that had been prepared to receive a fertilized egg. I want to also mention and encourage you that there are notes in my PowerPoint below each slide that you are welcome to read and use to help study. I think it will help you. Okay, this slide, I have the hyperlink right here. In case you didn't do it on the previous slide, please click here for a great review of the reproductive cycle. Basically, it's talking about how if you start up here with the menstrual phase as day 1 of your cycle, you enter, you have bleeding, and then the proliferative phase. At the end of the proliferative phase of the follicular part of the cycle, you get an LH surge that causes you to ovulate. And then we talk about the next part being the secretory phase, where the corpus luteum is putting out lots and lots of progesterone to grow this beautiful endometrium to prepare for the fertilized egg. And when you don't get that, when fertilization, or when implantation does not occur, then the endometrium enters into an ischemic phase as the corpus luteum declines, the hormones decline, and it's at the end of that ischemic phase that you get this sloughing off and bleeding, and you're back to day one. This is a picture that is very similar to the one that I had on slide number 4. I'm going to let you read about the most common menstrual disorder, menstrual cramps, in the notes below. The big thing to know is that primary dysmenorrhea is all about prostaglandins that originate in the endometrium, and that its secondary dysmenorrhea is usually caused by some other pelvic pathology, not prostaglandins. Primary dysmenorrhea usually begins soon after menarche, within the first year, and it's very common in women up through their early 20s, but does decline with age. It gets more manageable with age. The pain usually begins right when you start bleeding, and up to 15% of all women are incapacitated for up to 3 days with this every month. So it's a significant issue in women's health. Secondary dysmenorrhea usually begins later in life, and it gets worse over time. The pain may start days before you actually start to bleed, and it can get worse during your period, or may not be relieved by the end of your period even. So it's a significant pelvic pain that is going to last a lot longer than typical menstrual cramps.
When assessing a patient for dysmenorrhea, you're expecting to find a patient who's complaining of painful cramping with menses. It's not pain that they have any other time of the month. It's just that when they're bleeding, it starts, and it usually lasts up to 72 hours for most people. And it may only be a couple hours of severe cramping, but it could be several days. They may also complain of backache or pain radiating into their thighs. They may have nausea, vomiting, or diarrhea, or all three. They may complain of headaches. They may complain of extreme fatigue and also of interrupted sleep because of the cramping. So then there's this vicious cycle with lack of sleep and fatigue. And that's pretty much it for primary dysmenorrhea. If someone has other physical complaints like painful sex or pain with bowel movements, or they've got really heavy bleeding, or postcoital bleeding, they're bleeding after sex, or they're reporting infertility, they've been trying to get pregnant and aren't. These should all raise your index of suspicion that they may have secondary dysmenorrhea and are going to need a more thorough workup. Now, teens who present with this complaint, really, you do not need to be doing a pelvic exam on them unless you determine that they do have a risk for sexually transmitted infection, and you need to rule out STI and pelvic inflammatory disease, which are things we'll talk more about soon. But if the diagnosis can be confirmed with your history, a comprehensive history, a very limited physical exam is fine. And it's going to be a rare situation in primary dysmenorrhea, but fairly common in secondary dysmenorrhea, that you may want to go beyond your basic physical exam and order some imaging, like a transvaginal and pelvic ultrasound, to rule out other pathology. A patient who has a normal imaging and a relatively abnormal pelvic exam is probably going to need further evaluation, and I would refer for a diagnosis of endometriosis, or if you think they might have interstitial cystitis. Those are the kinds of things that you're not likely to be able to diagnose yourself. There are other musculoskeletal disorders, inflammatory bowel issues, and things like that that need to be ruled out. And you may have the expertise to do that, you may not. Our management of primary dysmenorrhea should always start with non-pharmacologic techniques, although honestly, most women are going to come to you with this complaint wanting pharmacologic management help. We very, very rarely will resort to hysterectomy or pelvic denervation to treat women with significant secondary dysmenorrhea. It's not a treatment. Surgical options are not on the table for primary dysmenorrhea. So non-pharmacologic management can be, heating pads, hot baths, stress reduction techniques, aerobic exercise, and even orgasm is a great aerobic exercise to flood yourself with some endorphins and help decrease the pain of primary dysmenorrhea. Aromatherapy has some evidence base behind it as a treatment for primary dysmenorrhea. Moxibustion is a Chinese medical technique that is also got some evidence behind it. And many people find that by changing their diet, limiting sugar, avoiding smoking, that these are things that, along with supplementation with vitamin E or omega-3 supplements, that these can also, over time, lead to less dysmenorrhea. For us, our main tools for pharmacologic management are going to be NSAIDs, combined oral contraceptive pills that we cycle women on continuously, or progestins that we cycle women on continuously. The NSAIDs would, of course, be used sporadically as needed during the period.
So, read through this case and tell me, is this primary or secondary dysmenorrhea, and what you think might cause this type of dysmenorrhea and what you might want to teach the patient. Then read through the notes below this slide and see what I thought. What is endometriosis and adenomyosis? There is this blue hyperlink here that you can click on to hear all about endometriosis, which is basically where you've got endometrial tissue. So here is just looking at how somebody can go in laparoscopically. This is a picture of laparoscopic surgery and somebody getting a little endometrial plaque here that needs to be cauterized so that it no longer bleeds with hormonal influence. One of the interesting things about endometriosis is that the amount of endometrial plaque that we see in the pelvis in no way correlates to how much pain a person's in. You can have one tiny plaque and be disabled by it. Some women can be disabled by that, and other women, you find it accidentally. You go in and you're doing surgery for some other reason, and you discover that they are covered in endometriosis all over their abdominal cavity, and it's really not causing them any disability at all or any pain. We don't really understand how the pain piece of this works, but it's more than just the presence of these plaques.
We know that women who have endometriosis often have it in their family tree. So we don't entirely know the factors associated, but it's an active area of research. We do know that it's more common in white women, and it's more common in people who have had early onset of their periods, early menarche. They are more likely to have short menstrual cycles. and they're more likely to have either bottle fed or only breastfed for a couple of months or a couple of weeks. It's not something that usually happens to women who are teenagers or who are perimenopausal. It's something that happens in the middle of their childbearing years. And it is also known to be associated with other pain syndromes and autoimmune diseases and atopy. Things like asthma and endometriosis often go hand in hand. So there's an element of this that is like, it suggests there's some kind of alteration in the immune surveillance system that is leading to endometriosis.
So how do we treat?
Let's switch gears now and talk about premenstrual cycle syndromes. When I say that, I'm really referring to PMS, premenstrual syndrome, and PMDD, which is premenstrual dysphoric disorder. I think of these two conditions as being on a spectrum with each other, where PMS is simply a less severe form of a mood issue, with PMDD being a much more crippling kind of experience for a woman. Once upon a time, we talked about how this was just in your head, except that the funny thing about that was that it was often noticed by other people in your vicinity before it would even be noticed by the person it was happening to. So it's curious that we thought of this as not being an embodied syndrome before. But we do understand it now to be related to hormonal fluctuations, even though we can't firmly elucidate precisely what it is that happens that makes it more severe for some women than for others. There is a lot of emerging evidence, however, that has led to better treatments. And interestingly, there are a lot of non-pharmacologic or alternative remedies that, even though they haven't been well studied, we see that with individual patients, they can make a huge difference. A little bit of history about the disorder. In 1994, that was when PMDD actually got classified by the DSM as a depressive disorder. And then in 2009, with the update, what we saw was that PMS and PMDD both now are in the category of mood disorder. And I haven't ever actually tried replacing my patient's blood with chocolate syrup, but I have to tell you that for myself, I've been severely tempted on more than one occasion. It hasn't actually worked. As you can see here, the vast majority of women experience some kind of symptom with their ovulatory cycles. It might be breast sensitivity or gum sensitivity when they're brushing their teeth, or they're craving chocolate, something like that. But it's 20 to 25% of women who are experiencing PMS where it truly has a negative impact on some aspect of their life. And up to 3 to 6% of women experience PMDD, where it is significantly affecting multiple aspects of their life, and they are finding themselves unable to function normally during those days at all. What are we talking about? Well, symptoms of PMS, of course, are going to be symptoms that are occurring only in the luteal phase and resolving within a few days of bleeding onset. They are recurrent month after month, and we do need to rule out other diagnoses, but the cyclical nature of these symptoms often makes the diagnosis for us. What are these symptoms? Well, in addition to the things I've already mentioned about breasts and gums, mood disorders, I would say, are the primary symptom that will be reported to you. Women will feel irritable. They'll feel very sensitive to things that people say or things people do, and they will often find that They are pushing people away when they most need validation from those people, and they may be nervous or feel depressed. It's a very many mood issues come into play here. People also have digestive issues. They can have lower abdominal cramping, and they may feel that they're retaining fluid more than at other times of the month, as well as having issues with headaches, menstrual migraines that begin right before a woman starts her period and then resolve within a day of getting her period. Those are very common for many women as well. But there are other kinds of headaches that can be more frequent during the weeks before she starts bleeding. How do we tell the difference between PMS and PMDD? Well, you need to listen to the woman. And on the next slide, I think it's the next slide, I'm going to show you a tool that you can use. You need to understand that PMS is simply a cluster of mild to moderate physical and psychological symptoms, like I described on the last slide. And these are always going to occur during the late luteal phase of menses and resolve when bleeding starts, or within 24 hours usually of bleeding starting. PMDD, on the other hand, is something that is going to affect many aspects of this woman's life, if not all aspects, and will severely impair her daily functioning. It will affect her ability to remain in relationships, perhaps, or severely stress her relationships. These may be, a PMDD will make a woman do things as a parent she would never do in a time when she wasn't experiencing PMDD. It can compromise her ability to work. She may get constantly written up for inappropriate behavior at work because she is so, her moods are so labile, and she has this aggressive streak that comes out in the late luteal phase. So it's the severity of the symptoms that differentiate the disease or the disorders from each other. And our goal in taking care of these women is to help them understand their experience and define and manage the symptoms that are causing problems in their life. I find that symptom assessment and monitoring is actually a huge part of the treatment for this disorder. And as the woman comes to recognize the timing of the onset and the severity and knows that it has a defined end when she starts bleeding, that is a huge moment of revelation for most women. And identifying specific areas of her life that are most affected, that she most wants to work on, can be a huge help to the woman. The first step in all of this is going to be record keeping. Her record keeping, and then coming and reviewing that with us. It gives her, it's a validation of her symptoms when we review these records with her and allow her to interpret what's going on with us. The link on the left-hand side of this page is to a manuscript with a copy of this screening tool that you see on the right side of the page. When we assess for PMS, there's no lab test that we can do, although we should consider ruling out thyroid disease, anemia, and pregnancy and diabetes, especially before we jump to the conclusion that we have PMS, especially if timing isn't clear to us. But having a patient keep a daily record of the severity of their symptoms for 2 consecutive months can give us great insight into what's going on, as well as using a tool like the one here. You do need to rule out other disorders that could explain these symptoms before granting particularly a PMDD diagnosis. But again, timing is so often the deciding factor. As I said earlier, the assessment itself can be therapeutic in PMS, PMDD. having done that, you need to focus on self-care for every patient. This is a huge part of the management plan, making sure that helping them figure out strategies that they can use to make sure they have a balanced diet, that they get sufficient exercise throughout the month, including the days that they are symptomatic, and that they get adequate sleep, and that they have strategies to help them manage their stress. People who have good social support can manage their PMS and PMDD symptoms much more easily. If somebody does not have good social support, talking to them about their relationships, talking to them about who they might foster a relationship with other than just us, because we are actually, our therapeutic support is critical for those patients, but we need to find them other networks outside of the healthcare system for them to draw support from. And often exercise is a place, if they don't have a community of faith, often an exercise group is a place that I send people. In the days when we had Weight Watchers meetings in person, that was another place where somebody could go and meet people who were committed to being on a journey together. So help your patient identify who can be a healthy source of social support. Then looking at non-pharmacologic therapies that might be useful to your patient. And all of this, I should say, is a conversation that you're having with them where they need to identify what sounds like it might work, what they're willing to try first, what they think they could work into their lives, because people aren't coming to us with this problem these are not women who are retired with no children at home. These are women who are working 1 or 2 jobs possibly, and they've got 4 kids at home, and there are lots of things going on. But non-pharm therapies, try one at a time. If you can get her, if she has access to an acupuncturist, great opportunity. Massage, if you don't have access to an acupuncturist, spending an hour or 90 minutes on a massage table for a woman who has the resources to do that, so that someone is taking care of her. That is, booking massage the week that you have PMS can be a huge self-care treat that can really have huge therapeutic benefit. If the massage is not something they're comfortable with, talk about having them go get their hair done. Go to a salon and have someone shampoo your hair and set and dry it or whatever they do, or get a pedicure, a mani-pedi. These are things that women with resources can do. If they don't have resources, but they have social support, these are the kinds of things you can get your sister to do or your aunt to do. Can she do a mani-pedi on me? Can you trade off and take turns? Can you do foot massage with your friends? These are things that can really help someone cope. There are also dietary supplements and herbs, botanicals, and we're going to talk about the pharmacology on the next slide. I think I've been talking about psychosocial strategies. Certainly some women do benefit from cognitive behavioral therapy, and a referral to that is in order as well, especially for folks with PMDD. I think I'm going to stop talking there and move on to the next slide. Pharmacologic therapy for PMS or PMDD usually starts with selective serotonin reuptake inhibitors, or SSRIs. We give these for just 2 weeks a month, beginning at the beginning of the luteal phase of the menstrual cycle, and then can discontinue them when the woman starts bleeding. Sometimes we also use oral contraceptive pills, and the idea here is to maintain an even level of hormone in the woman's body until we stop taking the pill and allow her to have a period, which will usually start within 24 to 48 hours of discontinuing the pill. And that's why it works, because you really shorten the amount of time she experiences PMS symptoms. Anxiolytic drugs have mixed results. You can try it, but do not give a woman diuretics. These will actually make her symptoms worse via potassium depletion. So women may ask for these, but don't do it. The effectiveness of various therapies is listed in your textbook in table 25.2. Thank you so much for your attention today in this lecture on the menstrual period and dysmenorrhea and premenstrual cycle syndromes. Please remember to listen to your patients, sitting down in the room with your patient and taking a big deep breath and asking them how things are going. Is always a good way to establish good patient rapport. But with women who are experiencing pain or mood issues related to their menstrual cycle, and you see how very common this is in the epidemiology we've talked about in this lecture, that moment of sitting down, making eye contact, and just breathing, asking them how they are, and letting them know that you're ready to partner with them to help them find a better life. It makes such a difference. Thanks for listening. Have a good day.